workshop. So my name's Brio Lehman. I'm an assistant professor at the statistical science department at UCL. And I'm delighted to welcome you all to this workshop on the challenges to statistical approaches for health equity. This is a workshop co-hosted by the Alan Turing Institute, which is the UK's National Institute for Data Science and Artificial Intelligence. The Diverse Data Initiative at Genomics England, which is a new initiative aimed at reducing inequalities within genomic medicine by conducting community-based engagement, building tools that promote equity in genomics, and doing whole genome sequencing for over 20,000 people, and data science for health equity. So we're going to spend a few minutes just introducing data science for health equity. Data Science for Health Equity, which we affectionately pronounce DISHI, is a global community of experts and enthusiasts working at the intersection of data science and health inequalities. And our overall aim is to ensure that the latest research and innovations in data science, machine learning, and AI improve everyone's health, and especially those in underserved populations. We are a cross-sector and cross-discipline community open to anyone with an interest in data science, health equity, ethics, and everything in between, including all those groups that you can see here. And if this sounds like you, then we'd love for you to come and join us. And there are a few different ways to get involved. You can, just subscribe to our monthly newsletter by going to datascienceforhealthequity.com. If you scroll to the bottom, you can pop your details in there. You can follow us on Twitter, and there was some exciting news that came in overnight. We reached our 1,000th follower on Twitter, so a huge reason to celebrate that for the community. And if you want to get really involved, then join our Slack workspace, where we have discussions. We share different articles, tools, and resources related to data science and health equity, and we're just generally a nice bunch of people. So we, as a community, we run regular activities across a variety of focus areas, which at the moment include genomics, data standards, social determinants of health, improvement science, and the focus of this workshop, which is statistical methods. So the kind of rationale for this particular focus area is that, well, our aim is to improve our understanding of inequalities and reduce health disparities through the development of better statistical and machine learning methods. So, the factors underlying health inequalities are generally highly complex, involving numerous social, cultural, economic, environmental, and genetic factors. And we think that data can shed light on these factors underlying them and begin to disentangle the different factors. However, we're also seeing more and more examples of clinical algorithms being used in practice that actually make existing inequalities worse, as a result of, for example, being trained on biased data sets. So here are just two examples of bias in biomedical research, showing the disproportionate amount of human genetic on this side and human microbiome data that come from European individuals. And when you compare that to the proportion of the world of Europeans making up the global population, you can see that there's a clear disparity here. And this is just one example in a couple of examples in biomedical research, and I'm sure we'll hear more about many more examples through the course of today's workshop. So the purpose of this workshop is to explore the main challenges to statistical approaches for understanding and reducing health inequalities. And our aim is to identify the common barriers to the effective use of statistical machine learning methods across the healthcare system, in particular with respect to these 4 points here, which is to understand the effects of health inequities in data and in statistical models, to detect and quantify unfair biases and their effects on health and healthcare inequities, to improve the equity of statistical approaches and mitigate unfair biases, and also to understand, I think, importantly, to understand the limitations of statistical approaches to mitigating these biases and addressing inequities. And I'd just like to dwell on this last point for a moment. I think, well, we're aware health inequalities are rooted in in wider socioeconomic inequalities. And whilst there is an important role for statistics and machine learning to play here, we can't just rely on technical solutions to solve all of society's problems. So we should also recognize that there's only so far data-driven tools can get us, and I hope that we'll have a chance to discuss these limitations in today's panels. And I'm delighted to say we've got a stellar lineup of experts from across academia, medicine, public health, and industry as part of 3 panels on healthcare delivery, public health, and pharmaceuticals. And we'll be using the themes that arise from today's discussions as the basis of a literature review into statistical methods for health equity. So thank you in advance for coming along and engaging with the workshop. It's really important to have as wide a range of perspectives as possible. And so we're delighted to have so many of you here today. Just some housekeeping before we kick things off. This is the agenda for today. So we've got 3 panels, as I mentioned. The first one starting in just a couple of minutes on healthcare delivery. And then we'll move on to an open discussion in breakout rooms. And just to preempt what's going to happen here, essentially we'll open up 3 breakout rooms, 1 on each topic of each of these panels. And this will be a chance for you to answer some of the questions that we'll be putting to the panelists and to essentially add your voice to the discussion. So really looking forward to that. Please do stick around to engage with these breakout rooms. After this open discussion, we'll move on to the public health panel and finish off with a panel on pharmaceuticals. Please note that the workshop is being recorded. If you'd like to not be included in the recording, just keep your camera and microphone off and you won't be included. Given that we have quite a few people attending the workshop today, which is great, we'll be using slido.com to source some of your questions. So I'll share those links to the Q&A at the start of each panel. And if you could just pop your questions in there, you can also upvote different questions that other people have already put on Slido. And this will be a way to kind of, allow the chairs to put these questions to each of the panelists. If you're on Twitter, and we highly encourage you to tweet as your live tweet as you're following along with these panels, you can use the hashtag DSXHE for Data Science for Health Equity to keep the conversation going over on Twitter. Great. So I have sped through my introduction slightly quicker than I expected. So I will just pause for a minute before I introduce our chair for the first panel, just so that people who have just joining us late don't miss seconds anyway. So yeah, it's my great pleasure to introduce our chair for the first panel, and that's Dr. Honghan Wu. Honghan is an associate professor at the Institute of Health Informatics at University College London, and he's a fellow of the Turing Institute, where he's also a co-organizer of the Health Equity Interest Group. He leads a health informatics group at UCL, and also co-leads the Edinburgh Clinical Natural Language Processing Group. Before I pass over to Honghan to introduce the other speakers, I'm just going to gently remind the speakers that we're running to quite a tight schedule. So I've given Honghan permission to preside over the panel with an iron fist. So you have been warned. And just to kind of make things a little bit easier for Honghan to manage, if you could, whenever appropriate, to use the raise hand button to speak if it's just an open question. So without further ado, let me pass over to Honghan. Thank you, Honghan.
Thanks, Brooke. Welcome everyone to our first panel. Healthcare delivery is kind of exciting topic, and we do have great panelists, as you can see in the list. So how this going to be organized? Basically, we start with 2 minutes. I'm going to start introduction of each panelist of this panel first. And then I give each panel a list 2 minutes time to introduce their background, particularly related to this topic we're discussing today. Then we do have a list of questions we prepared for the panelists. And then we open for the audience to ask their questions. As Björk said, please make use of Slido so that we know which questions people are most interested in. Please upvote if interested with a list of questions people put in there already. At the end, I will give panelists the opportunity to wrap up based on what we discussed. Okay. Now I'm going to introduce our panelists. First, we have Karthik Sivashankar, and Dr. Sivashankar is the Vice President of Equitable Health Systems in the Center of Health Equity. Sorry, if you don't mind, just shake hands so people know who you are. Thanks, Sivashankar, Dr. Sivashankar, and the American Medical Association, and a medical director in quality and safety and equity at the Brigham and Women's Hospital. Our second panelist is Dr. Joe Koresh. Dr. Joe Koresh, great. Is the George W. Comstock Professor of Epidemiology and Biostatistics and Medicine at Johns Hopkins University. And he's an international expert in aging and vascular disease epidemiology of the kidney, heart, and brain, using a range of epidemiology and data science methods. Thanks. Our third panelist is Dr. May Stafford. Dr. Stafford is, is a senior analytical manager at the Health Foundation and is leading a program of work that aims to use data analytics to understand patient characteristics, the demand of health services and health system factors that may contribute to achieving better outcomes for the patients. Welcome. Our next panelist is Dr. Oife Morley. If I pronounce your name wrong, please forgive me. Dr. Morley is Senior Analytical Advisor for Healthcare and Inequalities Improvement at NHS England, and consultant in infection disease and acute medicine in the Royal Free Hospital, focusing on health systems improvements and healthcare of vulnerable people and women and migrants. Welcome. And our final panelist is Dr. Mazet Gassini, and Dr. Mazet Gassini is Assistant Professor at MIT in Electronic Engineering and Computer Science and Institute for Medical Engineering and Science, and the Vector Institute faculty member holding a Canadian AI chair and Canada research chair. And she holds MIT affiliations with the Jamel Clinic and CSL. Welcome. Okay, that's our panelist. As you can see, it's kind of exciting and mixed of background and institute. So next agenda, basically, I'm going to give each panelist 2 minutes time. Okay, 2 minutes on their interested background in health equity and how statistical or machine learning is used in their line of work to understand or reduce health inequalities. Okay, let's start with Dr. Sivashankar. I hope it's okay.
Yes, thank you. It's a pleasure to be here with you all. So my name is Karthik Sivashankar. I'm a psychiatrist by trade, as mentioned, a medical director, quality, safety, equity at Brigham Women's Hospital, and then vice president for equitable health systems at the AMA. And I'd say that, it's an honor to be on this panel with experts like yourselves. I'd say I'm at the core an implementation person, meaning my focus is really on how to operationalize the work. And so I've really been at that intersection of quality, safety, and equity, thinking about how do we leverage high performance quality and safety practices to actually advance equity, because there is no such thing as high quality inequitable care. And yet we consistently deliver highly inequitable care. And so I've always been using data through that lens of how do we apply data and equity data principles to actually advance care for patients and communities, and look forward to talking about that with you all.
Thanks. Dr. Koresh?
Good morning. Thank you very much for the introduction and opportunity to talk about this. It is an exciting and interesting time. I'm a vascular disease epidemiologist, so I sit at Johns Hopkins and I run large cohorts and run some large global consortia. As a vascular epidemiologist, I've focused on the kidney, the brain, and the heart. All of these diseases have large health equities, so in a sense, getting to better equity is an important goal that I've thought about for a few decades. And I've experienced various challenges we can talk about. I may be a more pragmatic, quite interested in machine learning, but often with new technologies, my own approach has been to challenge the new kid on the block to make sure that they do better than the old kids on the block. In terms of being an epidemiologist, I look at disease prevalence, risk, disease definition based on empirical data and staging. And we've done a lot of that for chronic kidney disease, where we can draw on some examples, where in 2002 with Andrew Levy, we helped establish some of the standardized definitions for kidney disease that are used globally. That also included staging by estimated GFR, which estimates kidney function. We used a very simple equation, but somehow got it automated into the lab. So now it's reported by the majority of the labs in the US and many of the large labs throughout the world, with strengths and limitations, which we can discuss. Some of them relate to the inherent marker for kidney disease, which is unfortunately biased by race and diet and muscle composition. So we've tried to deal with that and improve it. So thank you very much.
Thanks. Next, Dr. Staffel.
Hi, everybody. So I started out as a social epidemiologist, and I think key approaches that we learned from social epidemiology when we were there was about modeling inequalities at multiple levels, recognizing that people might be experiencing disadvantage in multiple domains, where they live, where they work, in their families, and so on. And then also thinking about the solutions that have to tackle those will also have to be in multiple domains. And then also we were looking at longitudinal models that examine life course factors that affect health and aging. So looking at the long-term impacts of social, economic, health factors in childhood and early adulthood that then have long-term consequences for people's health in later life. And now at the Health Foundation, where we do have a focus on the wider determinants of health, but we're also working to mitigate inequalities in the health and care system. And particularly, I think what data analytics team brings to that is a detailed analysis to try and understand and describe the inequalities, some evaluation studies that look at how healthcare initiatives are working for subgroups as well as for all users. For the most part, we use routine health data, national level, but also our network data lab has local level data sets where NHS data has been linked to social care and other local government data. So yeah, the topic of inequalities is a massive one, and I think it's not possible to be on top of all the relevant work that's going on. So I'm really looking forward to taking part in the discussions today and hearing from others. Thank you.
Thanks. Dr. Morley.
Thanks very much. So hello, everybody, and thank you very much for inviting me to speak with you today. So I'm a consultant in infectious diseases and acute medicine. So I think, from the clinical side of things, we see health inequalities and inequity baked into everyday clinical life, especially in infectious diseases. And I think COVID and the sort of Public Health England report on the disproportionate impact of the COVID pandemic on people from Black and minority ethnic communities sort of really shook up our whole approach to healthcare data and implementation of the findings and, trying to do quality improvement with an equity focus. And so I'm the National Senior Clinical Advisor for Healthcare Inequalities Improvement in NHS England. And I just wanted to emphasize that my focus is very much around, articulating the scale of the problem and then really using the data to inspire improvement. So it's really trying to, first of all, highlight the discrepancies in outcomes and the unfair systematic differences in healthcare experience, process, and outcomes that are experienced. And then, the next steps in terms of what we actually do with that data. I think one of the major challenges is incomplete data, and we're struggling with this across the board. So I work very closely with the national clinical audit teams, looking at all the existing data that we have collected, because I think it's not a question of wanting more and more data. It's actually having the right data, having the skills to analyze it, and one of the major problems is trying to interpret the findings from the data. What does it mean if for example, if Black women are 4 to 5 times more likely to die during childbirth in England this year? What does that mean for us in terms of how we change that in the healthcare system? I think one of my fears about the vast amount of data that we have over the whole 75 years of the existence of the NHS is that we become complacent with our persistent shock in how bad things can be for some communities. And so this is why I think, we're really focusing on, there's been a catalyst in that Public Health England report on the disproportionate impact of healthcare outcomes in COVID, but it's been quickly realized that this is across the board. So we know that people from deprived communities live 20 years less long when diagnosed with cancer. They're diagnosed with cancer at a much later stage where it's impossible to treat other than palliate. And we know that people with severe mental illness are disproportionately affected with other comorbidities, but also more concentrated in deprived communities. And it goes on and on and on. And so I think the challenges I would like to discuss today is, how do we kind of take that leap into declaring that we have enough data to act on, and committing to really challenging people to not accept the discrepancies in the data. We know that difference in terms of, say, Asian communities have much higher rate of, or some people say predisposition to diabetes. But I feel that this shouldn't mean that outcomes are worse. So we should be able to absorb that predisposition with excellent treatment, excellent health education, community involvement and engagement, and really good data on measuring outcomes and improvement. Thank you.
Sorry, Dr. Cassini.
Hi, so I'm Marzia Gassimi, and I run the Healthy Machine Learning Lab at MIT. A lot of what my group focuses on is trying to design machine learning models that work well in health settings, which means that you're able to take in data that's often sparse and has a lot of biases and still do reasonable prediction that is robust, private, and fair. And then a little bit of what we have started doing recently is understanding, once you have a machine learning model and you want to reapply it to a healthcare setting, the one that it was generated from, or maybe one that's related, what are the challenges with reapplying it? And some of those challenges could be technical. So it could be because, for example, you want to deal with data distribution shift or some other, population difference. But a lot of them recently that we've looked at are also related to human process issues. So if you have a very, very good classifier and you give advice to clinicians, they don't always listen, right? And the model will be wrong sometimes. And in those cases, you also want to give information to people in such a way that if the model is wrong, it doesn't turn off their critical thinking skills. And so I think there's a whole sub area of interaction between advice, which, is ostensibly generated by AI in our setting, but does not have to be. And clinicians in practice that has been understudied and really needs more focus, because if we're going to be designing tools that may come with biases because they've been learned in biased settings with biased data, we probably want a really good understanding of how best to deliver the information from those tools to end users.
Thanks, it's great. I think we have learned a lot from our panelists about their background, the very important problems with health equity issues. So now I'm going to go to a list of questions that we have compiled first. And the first question for all the panelists, what are the most salient sources of bias? For example, a responder bias, selection bias, or information bias that you encounter in your line of work, and why? I don't know who want to take it first. Yeah, Dr. Kathleen.
I'm happy to talk about the two that I usually encounter. So I think the two that are most pernicious in the research I've done are actually selection bias and confounding bias. Selection bias, I think, is a really accessible thing that we've likely all encountered, where you've only measured things in specific populations, you only look at, specific settings. And this, I think, also makes sense to us intuitively, right? Where we understand that anytime you take a sample, often you take a convenience sample. And so the data that we tend to have, we have more data on people who are sick. We have the most data on people who are very sickest, right? And we have data on people, in settings where maybe they have better access to different kinds of academic medical centers. And now we're training all these tools, both machine learning and non-machine learning based, right? There have been clinical risk scores for decades, and they all suffer from selection bias. And so, there's been many really nice, no machine learning included, papers written recently saying, all of these clinical risk scores that we use, they don't work very well for a lot of people. Sometimes it's for minorities, and sometimes it's for half of the planet, like women. It just doesn't work for women. Sorry, guys. Which is crazy to me. When people say selection bias, I'm like, we're not a minority. There are a lot of us. We're really easy to include in a sample. And the other one that maybe is less intuitive, but extremely difficult to remove, specifically in machine learning settings, is confounding bias. Healthcare data is incredibly confounded in ways that we do understand, and I think have been written about intelligently, and in ways we do not understand, and I'm consistently surprised by. And confounders are easy shortcut variables often, or proxies for those confounders are. And so there was a great study that was done a little while ago where they found that, if you want to build some sort of model, either machine learning or non-machine learning based, that looked at somebody's propensity for needing acute care in the hospital, what mattered more was the time that labs were drawn than the actual value of the labs themselves, right? Because, the fact that I'm willing to wake you up at 2 a.m. to do like some sort of blood test is very informative. And the information that comes out of the test is a little bit less informative. But examples like that, I think, are really instructive, because often what happens is we have models that are just ingesting all this data about practices that we know are imperfect, but maybe we haven't really documented or fully, acknowledged broadly what those imperfections are systemically and what we'd like to remove. And so I think confounding bias is maybe more pernicious because it's harder to find, and it's maybe less well understood broadly.
Superb. Just following on that, and my own thinking, people always talk about, current day nowadays, deep learning stuff, just put every single features you can think of in, you hope this can, magically solve your problem. What's the kind of consequence of that in terms of confounding in these kind of models? People actually could not understand what the model is doing.
Yeah, it's the truth. And I think when we look at a lot of deep learning models, and they come back and then they work really poorly in some settings, or they automate substandard care for women or for minorities, we're surprised, but we shouldn't be surprised, right? Like, the data is there. You are showing it the data. This is actual clinical practice. Why did you think it would do something better when you told it that the right label was the thing the doctor did? And it's not like we have mistakes annotated. That doctor, he murders all the women he sees. It's not there in the data. Why did we think it could somehow, take a leap over when we didn't instruct it to?
Yeah. I see a hand up. Dr. Sevashenko, you want to follow up?
Yeah, thank you. And so I've been kind of leading up to this talk wondering, why am I here? Because I'm probably the outlier in terms of, having statisticians and epidemiologists on the panel. But I think I'm starting to realize that maybe my potential value add right now is just to get us grounded a little bit in some history, because I think sometimes we will start talking about these topics way downstream. And I want to just have us reflect on them, just for a moment upstream. So I was actually looking back at some of my own articles just from a few years ago where, for example, I was talking about it in terms of racial disparities. And when I was using the term racial disparities, I'm pretty sure that was because the editor had asked us not to use racial inequities or racism. And they were basically editing us. And why does that matter? Well, it's because our words and our narratives matter. They shape who we are, how we, what we value, what we decide to measure and not measure, and ultimately what we decide to take action on or not take action on. And so you can't really talk about data without talking about the narratives that underlie that data. Because at the end of the day, what we're really talking about is what we value and who we value, because we measure what we value. So when we talk about, for example, the state of data quality in terms of race, ethnicity, other social constructs, it's because they're in a state of neglect. We have not measured because we have not valued these people and communities sufficiently historically. And we see that reflected in the data. And so it's important to just start by naming things. And the first thing I'll name is that healthcare typifies the sort of racism, classism, sexism, intersectional forms of oppression that is common in the United States, it's common around the world. And if we're going to address these issues, we can't just talk about bias. And I know we're talking about it in a technical way right now, and that's not lost on me, but we got to talk about what underlies that. And that's really racism and the other forms of oppression within our institutions, within our histories, within our education systems, within our walls. And I just want to also provide a little bit of grounding in terms of when we're talking about race and ethnicity, I don't want to make any assumptions about what people know or don't know. So just to be very clear, race and ethnicity are social constructs. They're made up constructs. They were made up by, a number of different racist scientists in the past, including, for example, Johann Blumenbach, who would look at the skulls of deceased individuals and looking at the shape of them would try to make predictions, and visited the Caucasus and thought the people there were some of the most beautiful in the world. And so made up this term of Caucasian and then created a sort of hierarchy of different racial groups, Mongolian and Negroid and others. And so this social construct then got amplified, spread, it got codified in law in the 1700s as a way of justifying and preserving slavery, a way of keeping Black people perpetually enslaved and white people receiving a special status. And that has then been perpetuated in history, including into organized medicine and science. And so we see it continually used today in terms of race as a genetic or biologic construct, where it really is not. And we see that, for example, one of the panelists, Dr. Koresh, mentioned, he's focused on, I think, kidney, heart, and something else, brain. Well, if we talk about kidney, EGFR calculations, an example of racist, race-based calculations. That's where we're using race as a social or genetic construct inappropriately, when we really should be using it as the best proxy that we have currently for racism. And so using it in that way has led to unequal access for basic services, life-saving services. When we see I'll give other examples, but I'm going to pause here. I just want to provide that important framing, which is, yes, let's talk about bias. Let's talk about algorithmic bias and so on. But let's not forget the structures and the systems that we're working within. And let's not be surprised then when the data quality isn't there or when our AI is picking up on or perpetuating harms and forms of bias.
It's great. Yeah, I see a few hands up. Dr. Morley first, and then Dr. Courage. Okay, and then Dr. Stefan. Yeah.
Thank you very much, Dr. Sivashankar. I think just wanted to really thank you for bringing the sort of real life racism and discrimination into this debate. And I agree with Dr. Ghasemi. I think, you know, selection bias is really tricky. But I just wanted to talk about, you know, and just build on the point around racism and discrimination in terms of testimonial injustice. So I think, you know, we have got a lot of missing information, but there's a problem here in terms of involving people and communities in research, you know, and also listening and hearing people and giving people an opportunity to voice their views. In healthcare, in particular, in healthcare inequalities, we know that we have a lot of responder bias because of the sort of inequalities that are stacked against people. For example, in terms of blood pressure treatment in some deprived communities who don't qualify for prescription exemption charges, but they report, you know, taking all the blood pressure tablets all the time so as not to disappoint the healthcare professionals. And so this becomes data that's incorrect and is recorded as a sort of a failure of medication. And we are seeing this in some national analysis of prescribing data and inequalities in prescribing. I just also wanted to mention about classification bias, where, you know, we see a signal in the data. For example, we know that Black children in England get tonsillectomy less frequently than white children. And then this immediately raises lots of unpleasant discussions around health-seeking behaviors, cultures in different communities, whether that's, you know, pushy white mothers or overuse or underuse of healthcare. I think we should be very cautious about interpreting signals in the data and classifying healthcare need based on reported data.
Thanks. And Dr. Courage?
Hi, well, thank you. And, you know, excellent comments so far. A few to add. I put in the chat a classic reference that I think is worth reading and rereading, The Mismeasure of Man by Stephen Gould, related to the previous comments about how people's use of data, which may appear objective, have actually been very subjective and actually connected to socio-political biases and led to further perpetuation of those biases. A couple of other comments, you know, there was a comment about the electronic medical record type data. I think one of the things that's been useful in our work is to do meta-analyses and compare results across different types of data sources. And I think looking and seeing robustness across settings and data source where EMRs are often larger and cohort research data are much smaller but much more rigorous has been very helpful. And my lesson has actually been that for major risk factors where there's a fairly understood biology, I've been actually very pleasantly surprised that these large, dirty data sets do quite well. For tricky, nuanced questions that we may never be able to answer with either side, you know, watch out. So I think that's been helpful. Another major comment to make, I think for the people doing new machine learning, one of my comments would be, try and be rigorous about your benchmarks. Too often we see articles, and I've seen in major literature, something by Google, oh my God, they can predict who's going to get kidney disease. But it turns out they ignored everything else that every basic clinician knew and beat the null hypothesis, which anybody can do. I think often when we've done like the machine learning types of things with omic methods and genomic methods, will give you a lot of wonderful information. But humbling is the fact that if you include basic clinical measures and basic algorithms and risk scores, the incremental improvement is not very large and probably the part that's hard and variable. One of the challenges I would say is, what if the machine learning tools used global risk scores and global understood algorithms as one of the inputs, and then tried to optimize locally and check incremental improvement, right? I think it's a big difference, this pre-training and making sure you start not from the null, but from the best possible knowledge, even though it can be a little anticlimactic because then it's harder to get as much improvement. And maybe a brief comment about the GFR situation. I think we've made progress. I think the criticism has been useful. And the nice thing is, within a year of embarking on systematically correcting this, we've both published a new equation that's without a race term. We've shown that the bias that the race was trying to account for, it's funny, right? Actually, including race was trying to counteract a bias in serum creatinine, which is a marker, and we don't know why a biological marker has correlates that are statistically highly different by 16% across self-reported races, which are poorly defined and have huge other factors. But it turns out sacrificing that doesn't lose much accuracy, so now there's a new equation and a new recommendation. In fact, over the last 20 years, I think using the existing tools has narrowed some of the inequalities, because a lot of the issue is that people don't do any of the basic things. Maybe the final comment relates to what one of the earlier speakers talked about, which is making sure that the tools are acceptable to clinicians and actually help and complement rather than completely trying to replace, because I think that's sort of the goal for progress. Thanks.
That's a very good point. The final point, I think, especially related to this delivery stuff, you actually work with the clinicians. Yeah, definitely. To work with them. Yeah, totally agree. Yeah, Dr. Stafford?
Yeah, this is to echo and build on the remarks that have already been made about the structural inequalities in resources and how they play out, even within the NHS. So we particularly use primary care data, and my colleagues have, and many others have shown that sort of areas can be underdoctored and underfunded, and then that plays out in people having more difficult time getting an appointment. And also, so the unmet need for healthcare is a thing that we come up against all the time. We don't know to what extent that's playing out just based on the health record data. But then that also plays out in terms of the data quality, and there's been work showing that data linkage is more difficult to do. The more data linkage errors for certain groups, certain subgroups. For example, where sort of typical standard Western names are not, they're not so easy to link. So we really need to understand the biases that are coming through data linkage as well, and that's particularly important to sort of get a handle on where the inequalities throughout the patient pathway are kind of clearest. So there's two biases from us.
Thanks. Thanks, everyone. That's our first question. I'm going to the second question. If there's no further comments people want to make for the first one. The second one is about what have been done, basically. Specifically, what, if anything, is being done in terms of detecting, quantifying, and correcting what we discussed about the bias in the data. For example, imputation, reweighting, modeling. People doing a lot of work. Any comments or suggestions regarding that kind of problem? Yeah, Dr. Cassini.
I'm going to say something because I unfortunately have to leave at 10, so I wanted to make sure to say from a best practices viewpoint, the way that we're trying to address this in not just in my lab, I think broadly in the machine learning for health community, is look at the pipeline of what gets you to a finished product and then understand what are levers you can pull and what are levers that are not available to you that are caveats, right? And there are going to be caveats to everything we do. And so at the start, if we think about biases that maybe you could address on the data side, right? The data, is going to be imperfect, right? And so there are methods that people use. There are things like imputation or using synthetic data or trying to do some sort of like match scoring for selection so that you don't have such a skewed data set. These things don't always work, right? There are limitations to the amount of progress you can make with these small technical levers that you're pulling. Fundamentally, we need data that, as this great panel of speakers has said, reflects the diversity of humans who actually experience different forms of health and experience different forms of healthcare. I also think that once you have, the best data that you can get, right? There are some methods that people try to do on the modeling side for balancing, right? So these are things like you can change the cost of misclassifying different categories, especially if they are rarer, or you can try to change your objective function in optimization so that it doesn't so aggressively remove and ignore outliers, because in health, outliers aren't, data aberrations, they're just different people, right? And you don't want to say, this outlier, we can't classify it, right? This human is too different than the rest of my sample, which is the norm in machine learning models. All those optimization methods that we use in logistic regression, nothing fancy, right? Just logistic regression. How do you think it decides which variable to include? Right? It's ignoring the outliers and saying, oh, that data, it's not so important. Let's fit to the pattern, which is this average. And unless you know that that's what's happening, and to tell the model, don't use a method that fits to an average, go for a median, go for something else, look at different subgroups. You're by default going to create models and weights and methods that only work for this really nice middle part of your distribution. And then also, I think kind of after you've done the best data that you can, right? So you've tried as much as possible to address, all the biases that can leak into collecting your data, defining your outcomes, and then you've created the best method that you can. There are really difficult questions that I think, again, we do not have answers to right now. A model is going to have gaps. It will not perform perfectly on all people. There's no way, because nothing performs perfectly on all people. How do we want, and this is an ethical question, right? Like, how do you want to take that, knowing that it has specific imbalances in its performance that we can define, we can like write out a sheet of how it works, and actually use it? Because we need these tools to be useful. And so we need to consider the context into which they're being deployed. I think the things that I'm most excited about are methods that acknowledge that often machine learning models take in much, much larger amounts of very complex data that maybe we wouldn't normally have used in the past, and then enforce balancing in a multimodal way. Right. And so try to insist during learning that we will not accept any sort of learned function where the loss is significantly different in different ways along different axes of demographic groups. And so I think there are exciting ways to make progress, but we're not there yet. This is a space we need to work in.
Thanks. I know you have to go in a few minutes. If you have any specific burning questions for our last speaker, just mention this in chat or slide. Okay, Dr. Shankar, please.
I feel like Dr. Agasemi is like setting me up every time, so thank you. And please tell me if I'm saying
Throw
your
the
name.
ball.
So I'll just add to that, and I'd be curious to learn from those who are in the UK like how the state of data is there with the NHS, because I just don't know. I'm not as familiar, but I'll say at least in the US, a big place we need to start is just a standardized taxonomy. You know, how are we actually classifying these social constructs? Because it's a real mess currently. If you look at one health system or even hospital compared to another in the same health system, they're using completely different categories, and some of them are very outdated. Some of them are just still, you know, from today's standards, quite discriminatory in terms of the terms. So we need a standard way of using these social constructs, so we're all collecting the same thing and talking about the same thing. And then we need to make sure that the quality of the data is reliable, and that begins with making sure it's self-identified data, that it's not someone just looking at a person like, you look like you're African American and therefore I'm going to classify you that way, but where they're actually identifying themselves. And to that end, we need reliable practices for data collection, which we don't have. We don't really have standardized best practices across the country for how we collect this data and be sure that it's actually good quality data. And as we're doing that, we need to also have a better understanding about why we're not collecting the best quality data, or potential barriers to that. For example, historical mistrust, why people and communities may not trust us with their data. And there's a lot of good reasons for that. I put in the chat that we are launching a National Health Equity Grand Rounds at the American Medical Association with a bunch of other organizations. And the whole idea is to have open, free conversations on some of these really difficult, complex topics. The first one's talking about the history of medical experimentation and exploitation in healthcare. And it's with Harriet Washington and others. But that's important to understand in terms of why someone from a community may not want to share their data with you, or may not want to provide data that could potentially be used against them, because we have used it against them and we are continuing to. I'll share another article. It's by Vyas and colleagues. You've probably seen it. The EGFR is just one of a dozen plus examples of how we continue to use race and ethnicity as biologic and genetic constructs inappropriately. I'd say another really important thing, if we're going to talk about what we're actually going to do, is design with people and communities. So, you know, I started by saying that healthcare is an industry that typifies racism and classism. Well, in this room, and I'm including myself in it, we have a lot of privilege, right? I have a platform to speak to you all, whereas most people, especially from the communities that have been historically excluded and currently are excluded, they do not have this platform. And so we're talking in an echo chamber of privilege to each other. And that has consequences when you're the ones designing, and you're designing without the people and communities. It's why we have inflicted over and over again so many harms. So what does it look like for us to actually design with people and communities to share power in that way? And then finally, I'll share that, you know, it's really important that we shift from descriptive work to action-oriented work. We don't need any more, this is my personal opinion, we don't need any more studies talking about disparities in healthcare. And I don't even like the term disparities, which kind of connotes that it's a gap versus an inequity, which is a gap that is pervasive, that is unjust, and that is preventable. So we don't need any more studies describing inequities, because we know they're pervasive, they're everywhere. Pick an outcome and you're probably going to find an inequity. What we actually need are solutions. And so I'll give you an example of what that can look like. You might be familiar with the heart failure study at the Brigham and Women's Hospital. So this was done by Michelle Morrison, Brian Wispaway, and a bunch of other colleagues. And this study is an example of how to use race ethnicity data correctly. And what they did was they looked at heart failure admissions. And after controlling for other factors, what they found was if you were white with heart failure, you were more likely to get admitted to the specialty cardiology service, where you got much better specialized treatment. And if you were Black with heart failure, you were more likely to get admitted to the general medicine service. Now, this is probably because of systemic and structural factors, things like health insurance, but also because of bias as well. And so that's an example of using race as a proxy for potential racism. And when they tried to solve for it, and they are solving for it now, they created an alert in the EHR, basically reminding clinicians that, hey, this patient's African American or Black, maybe you should consider a higher level of care. That alert led to neo-Nazis organizing around the Brigham and Women's Hospital and protesting and actually handing out pictures and phone numbers of the physicians leading that study. claiming that they were trying to deprioritize white lives. So just a basic misunderstanding of what is currently happening, and even a misunderstanding that when we improve care for our most historically marginalized patients, we improve care for everyone because the care is therefore more reliable. So I'll share some articles on this, but I think those are some things I would highlight as kind of key points to consider.
Thanks. That's great examples. Really, really fascinating, good examples. Look at that time. I think I must be very quick for the next question. I really want to ask this question, given our topic is about delivery of healthcare. So the question is particularly for those on the panel who are, taking care of the patients. What statistical or machine learning tools are being used currently in your practice, and what potential bias can potentially affect that kind of decision-making tools in practice? Anyone would take this one? I think it's a very kind of practical one and potentially directly impact our patient care. Yeah, Dr. Stell.
Well, I'm in the analytical bit rather than the decision-making bit, but I have seen a lot of risk prediction algorithms really taking off, especially being developed during the early waves of the pandemic, right? The shielded patient list being a key example. And it's great to see that developers are increasingly looking at how those perform for different groups. At the moment, we're funding some work in Public Health Scotland that are looking at one of their algorithms to admit patients to hospital. I'm sure there are lots of other examples, but equally we've seen some reluctance as well amongst developers to expose themselves to having their algorithms looked at. So I think it'd be great if we could see commissioners really sort of requiring that more when they commission things, and so that developers are having more of a commitment to consider bias and inequalities, at least to be explicit about where they are and how they're going to be tackled, even if they're not yet kind of fully tackling them. Because I recognise there are trade-offs in terms of bias and accuracy and speed. I think we do need transparency about that.
Thanks. Dr. Mori, I saw your hand.
Oh, thanks very much. I mean, I'm not a statistician, so I would defer to other colleagues here in terms of, how to sort of deal with all these biases in the data. But I just wanted to draw your attention to a sort of a recent national government level inquiry that went into sort of biases in the data and biases in the equipment. So during COVID, our pulse oximetry monitors were found to give different readings depending on the amount of pigment in the skin. And so this led to, a huge, big media sort of trial by media into, oh, did this mean that, people with more pigment ended up going to ITU ahead of other people? And, in COVID all around the world, we had so many difficult ethical decisions around rationalizing intensive care beds, and that was sort of very difficult for many different reasons. But the problem was that actually the saturation probe was measuring the saturations as being artificially high, so giving a false sense of reassurance. But nevertheless, a huge national inquiry was launched into this, and so I just want to sort of really emphasize that sort of cautious interpretation of these signals in the data, and to really reiterate that caution about not exercising stigma or structural racism through our data. And we know, as Dr. Duxemi already said, that AI models are built in stigmatized and biased environments, and the biases are baked in and amplified. So I think in terms of clinical application of these tools, I think we still need to be very careful around our own stigma, and establishing trust, as I said earlier, and very careful interpretation of the results.
Thanks very much. Thank you, everyone. I think we need to go to the next section of this panel, which is the questions from the audience. So look at the slide, though, the most voted now, I think it's quite good one. We haven't really touched this very important question. So what is fair in this context? What do we mean by fair, right? And how can we measure whether an algorithm is equitable? So that's very important to interlink the questions. I don't know who want to take this. So what do we mean by fair here? And how to quantify, whether the algorithm is fair or not? Anyone?
Maybe I'll start a little bit, right? I think it's useful to sort of go back to things a lot of people have talked about, which is equity versus equality, right? And this concept of whether you really want to achieve equitable outcomes across all people, or you're trying to get just sort of this equal thing where the same types of people will get classified the same. But the problem is we have a history, as Dr. Sivan Shankar, if I said it close to correctly, has said, of racism that has led to a lot of inequalities now that need to be corrected, right? So I think we should apply those two bars. I think just the reason I spoke up is often for me, we shouldn't get stuck on the nuances when we have huge problems, right? So at least I would make a pitch to aim technology at big answerable questions and big gaps which can be narrowed, right? And there you can make a lot of progress using some fairly easy things. And maybe the next step to mention is when you talked about machine learning, it's most exciting to predict the future. But in a way, the future doesn't exist. And so you can never really be wrong. So I think I would challenge us to at least focus on the present, because diagnosis, if there are huge diagnostic error rates and huge misapplication of current recommended practices that vary by social determinants of health and race type categories, that is much more addressable, right? And much more transparent. So I would say that even if it's a little less exciting, focusing on diagnosis and misdiagnosis and immediate actions is important. Then in future risk, I think I've found the tools that have been most useful are ones that discriminate greater than 10-fold risk. There are a lot of contexts in which low risk versus very high risk is more than 10-fold. You get that right, you can connect it to action, you can actually move forward, and you can find big differences across social groups. And maybe my final comment is to combine human factors with technological factors, right? And maybe I can disclose a conflict. I've tried to consult with a company that's been working on this for the last 10 years, Healthy.io, where they do relatively simple things like combining the cell phone camera technology. People have phones, have cameras across a pretty wide social range of factors. And that can bring AI tools to the home, where actually you get the opposite effect, where people with jobs that don't give them pay for time off, right, doing things at home can be a big equalizer. But it turns out you have to combine the technology with human support, and then you can get fairly equitable rates of testing. This is for home urine testing in both the UK, where they've done it in the NHS, and now FDA approved in the US. Thank you.
Thank you very much. We do have a bunch of very good questions in the slide discussion list, but I'm afraid we don't have time for the session. But do take a look if panelists you guys have time and trying to respond if possible in the chat if possible. Thank you very much. I think that's our first panel. Thank you everyone. I think I really enjoyed a lot of open questions, of course, but very good, fruitful discussions. Great thing. Thanks.
to begin by asking the panelists what are the most salient sources of bias, responder bias, selection bias, or bias in the information that you encounter in your work, and why. What role does data representativeness, missingness, and diversity play in that? And I'm going to pick on Sarah to answer the question first.
Thank you so much, and thank you for having me here today. I always feel like a bit of a fraud when I'm on these sort of panels, because I know that people are doing very esteemed work with statistics and data science, and I'm here very much as somebody who is using data to try and inform decision making that people are doing in public health, and that's where I've worked for a number of years now. And just to explain to people what my current role is, so I lead a team who produce often situational awareness, so packs and information to senior leaders, so that's the Secretary of State and the Chief Medical Officer and similar, about what is happening now. And so we work primarily in infectious disease, and so these past few months my team have been monitoring what's happening for flu and with COVID. And I think if we get back to the question rather than kind of going on about it a little bit, it's that I suppose where we find our bias is in what is available to us. So when you are trying to inform decision making in very short time, unfortunately, we do not have the time or the resources to immediately go back and do additional work to find populations in data sets that might not be there. And so I would say that we're very much at the kind of the last mile, the end stage of decision making, and the decisions that have been made earlier on in the pipeline affect us a lot. So, for example, a very good example would be that over this winter, we had quite a few requests from colleagues who try and do work on migrant health, particularly in the UK at the moment. It's something that really came to the fore over the last winter. But our data collection around recently arrived migrants or people who have arrived, particularly off small boats, is very poor, and therefore what we can do in our end is very little, and it can be quite frustrating actually when we're actually sitting back and saying, well, it's the missingness. So it's when people aren't collected for very good reasons, or they're not in the data sources, then really as the advice that you can give to decision makers is very little. So I think that's quite a big topic, but maybe starting big, and then I'm sure others will have very insightful things to say on the other areas. I'll hand back to the chat.
Thank you very much, Sarah. I can well appreciate the problems with trying to collect migrant data in the current situation, and that in your position where it then becomes very difficult as you're at the end stage of data collection. Could I ask Owen or Bila from their perspectives in the observatory to share some light on the question that we were asking about the sources of bias and the roles that representativeness or missingness and diversity play in limiting what you can do?
Okay, thank you. Thank you, Peter, and thank you everyone who's taken the time to listen to us today. So I'll talk a bit about the bias, and then my colleague Bila can talk a little bit about some of the things we're doing with some of the data. Because I understand that obviously the topic for today is around the challenges, but it's also important to talk about some of the things we're trying to do. So in terms of biases and challenges around the data, I think one of the biggest issues from a race and ethnicity perspective is representativeness of the data. So I do know that I think one of the things I'll talk about, look at it from a genomics perspective. We know that genomics data predominantly comes from populations who, I think one of the papers sort of described it as weird, which is mostly white, educated, rich, and from democratic countries. So if that's the genomics data we're working with, is not representative of the world, but the understanding is that the findings are supposed to be sort of applied in a general sense when it's not representative. So that could be one of the biases. Then the other issue is around the quality of ethnicity coding. So obviously there are various issues around this. The first one is the completeness. We know that in healthcare data sets in general, I think about for 21% of the data, we do not know the people's ethnicity as a starting point. And then we know that there are different ethnic categories that are used in different data sets, and these are ever changing. So according to the NHS Data Dictionary, we should be using the 2001 census classification. And yet other data sets are using maybe more up-to-date, as in the 2021 census classification, which is even different, which makes it difficult when you're looking at long-term trends. So there's issue around the categories as well. And then there's issue around the granularity. So in some of the worst data sets, they use either a binary classification, which would be white or other, or others use what I call the 5+1 classification, which would be white, Asian, black, mixed, other, and unknown. And those data sets do not give you the granularity you need for you to fully understand what's going on in the data. Then the last challenge I would talk about, I could go on forever, is around dealing with small numbers. So in some of the work that you do, you end up with very, very small numbers. So from a statistical perspective, it's about how do you choose whether this thing is statistically significant or not when you're dealing with very, very small numbers. I remember doing a piece of work and we hired statisticians. I'm not a statistician myself, but we got statisticians to come in, and one of the gentlemen used a Yates correction. He said, if we do this, it sort of like reduces the bias of the small numbers. And when we're presenting the data, someone said, actually, the Yates correction is hardly used at all because there are concerns that at times it overcorrects. So that's one of the challenges that you when you're dealing with really small data. So I don't know, I'll let Pilar speak for a few minutes about some of the work we're doing around the data.
Thank you, Owen. Just in terms of what Owen was saying, a colleague at the King's Fund, Veena Raleigh, and I have written to NHSE requesting them to take action to improve the quality of ethnic data collection. In particular, it's many years since they issued any guidance to the NHS on how to collect it, and we've urged them to issue new guidance. And I totally take Owen's point about the classification being 20 years behind current thinking, whereas there is a 2021 census ethnic classification, which goes with the populations that are available all around the country to assist Bila in her task. So I think we've already identified there a relatively easy win to try and improve the quality again, because in particular, it's those people who don't respond or don't have their ethnicity coded by the NHS who vary most from the pattern of people who are included. So it is a significant bias, not just a lack of data. Could I ask Elizabeth to share some of her experience now?
Yeah, happy to. Thank you so much for having me. It's really nice to participate in this, and I know I'm going to learn a lot from everyone else too. My perspective is, I think, actually a little like a slightly different angle on this, in the sense that I am a statistician, although as stated, my primary appointment's in mental health. And so my work is very applied and sort of at that interface. And almost all of my work is around methods for causal inference, sort of estimating the effects of risk factors, programs, or policies, where sort of representation means something a little bit different. If we think about sources of bias, a common source of bias is confounding and sort of dealing with the fact that people who have access to some program might be different from those who don't in observed and unobserved ways. And so sometimes it's a question of what variables do we have in the data to be able to make sufficient adjustments to sort of really feel like we can disentangle the causal effect from other differences between the groups. A lot of my work, though, has been on the generalizability or the challenges with representativeness of randomized trials. So in many fields of medicine and public health, we've tended to sort of prioritize randomized trials to say these are our gold standard for estimating causal effects, and that is for good reason. They have wonderful properties of unbiasedness. But there's increasing evidence in a number of fields that the people who participate in trials are often not representative of the people that these decisions sort of might affect or might relate to. There in the US, FDA has looked into this and seen big differences in randomized trials for cancer treatments, for example, often have a disproportionately small number of minority individuals. I've done work in education where we see that the schools that participate in randomized trials often look quite different from schools across the country. And so I think partly one of my interests has been even just getting people to start thinking about this, sort of not that it's difficult to do a representative randomized trial. It's very difficult to do that. But I think we at least need to be honest about the samples that we have and sort of who we can be drawing inferences about. So again, a lot of my work has been in sort of how do we bridge population data, ideally representative population data, with trial data to help us understand that. I think I'll come back to this later, but I think one difference. Yeah. I'll come back to the claims data because there's also many in the US. I'll just put a pin and then we'll come back to it. Many studies in the United States use health insurance claims data sets, which are then among like privately insured individuals and certainly exclude many relevant groups. So I'll pause that for now and maybe we can come back to that in other questions.
Thank you very much, Elizabeth. And again, I've noted in some of the recent discussions, a particular issue has been on gender bias in some of the drug trials, for example, for heart attack drugs and treatments, not looking at heart attacks in women, which are very different to men. So I think that's another area to flag up. Rumi, could you provide perhaps the final word on this question?
Thanks, Peter. And I wanted to just start by expressing my gratitude. Thank you for the invitation to the organizers, and happy to chat and learn from everybody here. And also my comments, I had two specific areas to mention that really corroborate and reinforce kind of and complement what the other panelists have discussed, which are also very important topics. And maybe just framing them with a couple examples will illuminate this as well. And so I think the first one is on that data generating process. So I think Elizabeth just spoke to it in terms of like where data is coming from trials, and Sarah spoke to it as well. And I think, it's not one of the standard statistical biases we think about in terms of, maybe information bias or selection bias, but also coming from a computer science kind of lens, this is a common way to think about where the data is coming from before we even analyze it. And I'll give an example of mortality risk prediction models. We studied this across a data set of over 100 hospitals in the United States. And what we found is that there can be large differences in the distribution of data that we get for different groups, right? So the kinds of laboratory tests, the rate that they're measured, all of these things can look quite different. And it's also, well explored in other fields like the health informatics space, et cetera, that kind of healthcare practices can also vary by different groups. And so just kind of thinking about the data that we have, and one particular point to make is that understanding that process is important because it could obfuscate what we think are maybe disparities by race or ethnicity, but maybe the reason is the healthcare practice, not the data itself, right? And so just keeping that in mind before we start analyzing or using statistical methods. And I think the second point I'll make is what was slightly mentioned also by the other panelists in terms of maybe statisticians could call it specification of models or what variables we're including. And I would say from the health equity research, we often know that the upstream variables are quite important. And we can talk about that more, but I'll give an example of a lot of COVID modeling has been happening, very important, and a lot of new data sources like from Google and others about how people are moving around, mobility, the efficacy of social distancing. All of these things are very important. But you can imagine that if we only look at mobility, for example, right, and we look at mobility of different groups, that might incur a different intervention than if we also consider economic opportunity and understand that there's a pathway from that towards why maybe different groups have different mobility. And so understanding, what variables we include will also impact where we think of different interventions in that kind of causal chain. And so just a couple of points to add about the data generating process, and then also which variables we capture, particularly upstream ones, before we perform any analyses.
Thank you, Rumi. To move on to the next question about what, if anything, can be done to detect, quantify, or correct for these biases in data. Perhaps I can go back to Elizabeth there, because I think you were almost answering that in your contribution before.
Yeah, I'm happy to kick us off on this one. This is going to sound obvious, but of course we can only make explicit adjustments for things that we actually have data on. And so I see this in two ways. One is, certainly in my field, common approaches are sort of like weighting adjustments. So I've worked on methods where we can re-weight randomized trial samples to look like a population. But of course, we can only do that if we have consistent measures on those populations. If we know the distribution of important effect moderators in the trial and in the population. And so we need then good representative population data and measures on that population in order to do that. So that's partly, again, sort of the variables that we measure, but it's also the samples. And, I've been involved in a number of conversations on this topic because another, I think there is more and more interest in combining different data sources and sort of saying like, oh, well, if we bring these together, then it is more representative. And one thing and this is especially true given that, at least in the US, I assume elsewhere, our large scale kind of representative national surveys are getting harder and harder to operate. The response rates are very low. However, that is one of the few ways to get an actually formally representative sample. And in some ways, I think of it as it does sort of provide that calibration where if we're combining other data sources, we're never fully sure if we sort of really have people represented. So the migrant example is a really wonderful one in the sense of like, are those individuals going to be captured by any of these data sources? Maybe they wouldn't be in the representative sample either. But I think we have to be sort of honest about, we can use statistical tools, we can use weighting, we can do this sort of data combining. But I think, as Rumi was referencing, we also sort of still have to keep in the back of our head that it's probably not a full solution. And so that's where I tend to look to sensitivity analyses or sort of ways where we can kind of probe even we can do the best we can with the data we have, but then often we're going to want to build in some sort of sensitivity analysis to acknowledge that we also just don't have all the data that we really might need. Yeah,
thank you. Sarah, I saw you nodding at one point in that and possibly being able to talk about the UK HSA data pool.
Yeah, so I think I nodded a lot in that, but the bit that sprung to my mind was, and I will say it positively, and then there's a slightly negative way to look at this, or cautionary way, is that of course I do think that that data linkage can help. So in the UK for the majority of the population, and not all the population, and I think that's really important to keep in mind. You often can link across multiple health data sources to do work for public health benefit. And so over COVID, I do think our data collection, I know it's not data collection around ethnicity and vaccination has definitely improved. And so that then will have benefits for us when we want to look at other things, because we can start to be able to link data sets. And the ONS recently published some work comparing across different health data sets and how well ethnicity was recorded across different data sets. And so I think that kind of work is incredibly beneficial, because we can start to say, well, if you start from the point of, well, there probably isn't a gold standard, but what's the best that we have? So I think that's really useful. I would then also say that another thing that if we're thinking about the use of this in the day-to-day of health practice and public health is how valuable local knowledge is around communities and how different population groups might be living in a particular community, or where certain people might be living, and that kind of good old-fashioned shoe leather epidemiology and knowledge on the ground can really help understand geographic variation, which won't be obvious to somebody working nationally, but might be helpful for somebody working locally. I suppose the caveat that I'd add to this benefits around data linkage is, of course, you have to be very careful that everyone's comfortable with how you're using the data, how the linkages is taking place, and particularly if there are sensitive characteristics that we're using. And I do think it does come back to, I think a couple of the panelists have alluded to very thoughtful and careful use of this data, because I think we have seen instances in the UK, unfortunately, where data linkage has been used for vulnerable population groups to consequences that I don't think people would have intended. So I do think we have to keep that in mind as practitioners of data science as well.
No, absolutely. Consent is a key issue there, but also I think something Elizabeth was pointing to, which is that the individuals who you can't link are a very different group to those for whom you have got data. And so some triangulation with other routine collections is important. And I think as well as the UK HSA data lake, I'd point to the, you were hinting at it, Sarah, the ONS Data Economy Act, which has been used with agreement from other departments to link data, not only health data, but data to census and other sources. And of course, that gets even more sensitive in terms of the issues around consent and public acceptability. Can I ask Owen or Bila whether they would like to comment on this issue?
Yeah, sure. So I think some what I'm going to say is going to sound a bit repetitive. So I think one of the things I always say to people, double check the methodology that was used for the data that you're looking at. I think I cannot stress this enough. There's times when I've read reports which were highlighting certain inequalities, and I know that the data they're referencing probably wasn't of a quality enough to be to make the strong statements that people make. So when you reach out and say, you know, I've seen this report where you're referencing this mental health data set, how did you calculate this? Then you start to see that there are probably challenges in the methodology that was used. So always double check. And then the other thing on top is check how the data is collected and if it's collected at all. Because there's things like, there's a report we recently published which was looking at some of the key healthcare apps which don't even collect demographics data at all. So you just get a headline figure like, you know what, this app was downloaded by 30 million people, but you say, okay, can you give me the breakdown? You don't even know. And so, okay, it could be actually reinforcing some of the inequalities that we're trying to counter. And then the last thing is around comparing with the population, comparing samples with the population. It ties on to what everyone else is saying, that to make sure that there's a representativeness.
Yeah, thank you, Owen. And that, of course, in terms of ethnic population data, there is an issue that once we move away from 2021 and the census data, the quality of the subsequent population estimates does make it difficult to make those validation comparisons. We're not very good. We haven't been very good up to now at making those. So we're we need to look to those estimates being improved. Rumi, would you like to contribute?
Sure. Yeah, thanks, Peter. And I completely, agree with everything the panelists have said. So I thought I'd just focus on one more piece that I could add, and kind of to maybe enable a lot of these good points that the panelists have discussed regarding, linkage across different data sources, trust for the data collection, maybe avoiding unintended consequences, knowledge on the ground. I guess one aspect I'd point to here in order of what can be done to address some of the biases might be thinking about who is involved in the analyses process. I think speaking just to, I'm most familiar with the US and in biostatistics, computer science, we don't have great representation of Black populations, of Latino populations, folks, students, learning about these areas. And often it would be great to have folks who are, have the lived experience to understand what the issues might be, or can, reach to their own communities and develop that kind of knowledge transfer would help us with a lot of these issues. And so I'll just speak to that other added topic that could be done kind of more at that structural level. Thanks.
Yeah, I think that's incredibly important to get greater and wider representation in terms of analyses we are doing. Could I now move on to the question on statistical or other tools being used to inform public health policy, which are vast, that's a vast question, but specifically, how are some of these impacted by biases in the data? Again, could I go back to you, Rumi, to perhaps talk a little on that first?
Sure, thanks, Peter. Yeah, I mean, yes, to be honest, I think others who also maybe work more like Sarah, working more, at the policy level can speak to this a little bit more than me. But, my understanding from some of the work I've done in different areas, infectious disease and others, of course, just having an understanding of what's happening, maybe a very straightforward place to look at this, right? So like case data for different diseases. And we know that these are impacted exactly by the things all this panel has spoken to in terms of underreporting, differential underreporting by different groups, et cetera. And so I guess I would just add the kind of disciplinary pluralism in that. And as statisticians, it's nice to work with maybe folks more on the qualitative side who can give us some understanding of maybe why the data is not there, or what are the issues with the data that we then could use statistical tools to improve with, or further just data collection. And so I'll let the others speak to further statistical methods, which we all know are important, but maybe just starting off by that kind of collaborative approach with other kind of scientists who can help illuminate some of what could be limitations in our data and methods, so we can address them. Yeah.
Thank you, Rumi. Perhaps I think the pointer was going back to you again, Sarah. Would you like to talk about public health policy and what tools are available at the moment?
I'll give it a go. I think that one of the most useful tools that we have is really good visualization and storytelling. So I think sometimes when certainly I have found, and maybe others have found similar, that when you speak about inequalities and health equity, there is a certain amount of people thinking that they already know the story, or not willing to engage on it. And I think having really good visualization showing the impact of whatever it is that you're interested in, and that intersection with the different inequalities of interest, has been the most powerful tool that we have. And being able to do really simple, and I realize I'm saying really simple stuff, but doing really simple stratifications by showing the intersection and the importance of deprivation intersecting with ethnicity or with gender, and showing those differences and showing therefore where you could take action are really powerful tools. So I think that's where I have found most payoff with the investment. And I think also acknowledging that in the public health world and the response world, you also need to be cognizant that things do change over time, which is slightly different to some of the more constant things and constant inequity that some of the other panelists might be looking at and dealing with. That said, I would say we could only do the visualization and the simpler storytelling if we have that backing of knowing what's been happening in the background. So the more detailed statistical work of really understanding what's going on. And an example of this would be, so over this winter, we've been really monitoring difference in outcomes among different ethnic groups, but noticing that within the larger Asian category, and when you get down to subcategories, you can start to see real differences, particularly in the British Pakistani group. And that's something that I don't think we could have done a few years ago, and we have more confidence working on that because of the work others have done, doing more detailed statistical analysis on health outcomes within that particular group and problems with vaccine uptake in that particular group. And so that then allows you to tell a simpler story because you understand what's going on in the background, and others have done that work for you. So I think I just gave a really simple example, but it's only possible because of the deeper work.
Yeah, and I think I would add to that in terms of visualizations, the increased use we've been able to make of place-based analyses, looking at some of the issues you've talked about within fairly small areas and highlighting where issues are concentrated and then linking it to knowledge about those areas and those visualizations. That's easy for people to visualize and to Elizabeth, would you like to make the next contribution?
Thank you. Sure. I think I would just first say that it's kind of, as I already talked about, there are statistical tools. We can do weighting, we could do some fancy modeling, but I think we just always have to remember that the statistical tools and the data can only tell us about things that are in the data. And so I think we need to just be really honest about that. And actually where my main comment was going to be very consistent with Rumi and Sarah's, which is that, I'm a statistician, but over my career, I've become more and more convinced of the need for really strong qualitative and mixed methods work. And again, sort of just really those close collaborations with substantive experts who are going to know about what the data is, what is and isn't in the data. I do a lot of gun violence research here in the US, and from my colleagues and co-authors on that, have really come to understand, like, the existing data sets that are available, if you just sort of download them from sources, are, you have to really understand how to interpret the numbers. There are some weird coding things, like one of the main data sets, if there's more than 10 deaths in a given shooting, it just caps it at 10. So if you're looking at mass shooting events, it's not. And if you don't really understand the data and the context, it's very easy to just download it and like run with it and run all sorts of fancy models. And so I just, would really want to make a plea that, especially if we want to understand the limits of our data and who is in the data, we really need to work very closely with people who really understand the scientific contexts and the people who are in that. So really just echoing what Rumi and Sarah said.
Yeah, I think that's absolutely right. And also, before you do any more sophisticated statistical techniques, to look at the basic counts and the basic numbers before you jump into advanced statistical techniques. Owen, would you like to comment on this?
Yeah, so I think in terms of some of the statistical analytical methods that are used, I think the two common ones we tend to use is significant difference if you look at ethnicity. We say if you look at outcomes for people from different ethnicities, do you see any statistically significant differences in the outcomes between, say, someone from a Black background, or someone from an Asian background, and someone from a white background. Then the other method that's used a lot are the relative rates, to say like for a Black person, I think the one that's most known is the Black mothers are 4 times as likely to die during pregnancy compared to white mothers. So those are like the 2 methods that are used the most. But I think one of the things I would just, for people listening, is context is really, really important, and to always understand the numbers behind what you're looking at. Because for some of the headline figures, so if it says like, I used to do data on workforce, so it would be like a relative likelihood of, or relative rate in London of 1.3 might seem smaller than a relative rate of something like 2 up north. But because of the differences in the samples, the numbers, it could be that actually the 1.3 is a much, much worse outcome than the relative rate you see in a place that's not very diverse, where you've got a relative rate of 2. So always understand the context, look at the numbers beyond, and go just beyond the headline figures.
Yeah, no, and absolutely 2 points coming out of that. One, always look at the absolute rates when you're looking at relative rates as well, so that you can see the magnitude of the impact as when you get a relative rate. And secondly, I think going back to a point you were making earlier, when you're dealing with really small numbers of individuals or people with outcomes, then significance testing is your basic sifting technique before jumping to any conclusions. And I think we've partly covered it, but perhaps we can round up with the last question on the main limitations of using statistical approaches to mitigate data biases. Sarah, do you want to kick off just with that and summarizing any other points you want to make?
Yeah, no, I'm happy to. I suppose I feel that we have kind of covered a lot of the limitations of the statistical approaches, especially some of the other speakers, that it, for me, comes back to I suppose that there is not one magic statistical approach, and that you always need to have a really good knowledge of how data is generated. And I would add to that, I think the thing that perhaps hasn't been talked about as much, if I just have time to add it, is also knowing having some knowledge of the history of the group that you're interested in your particular setting, in your particular country, because that is likely to be different in the United States, for example, as it will be in the UK or in France or in Germany or wherever it is that you're looking at, or even in Kent versus up in the north of England. And I think if you don't know that, then you won't understand potentially how somebody might be interacting with the healthcare system, or might be more or less likely to take part in a study or a trial or a survey. And so I think it is saying, as data scientists or statisticians, that we also need to have that knowledge of, or work with, I suppose it's sociologists or qualitative researchers or people working on the ground in communities, ideally, so that we are choosing the right statistical process and analysis process to suit the question that we want to answer, which is slightly broad and wishy-washy, but I suppose that's the only way I've ever found to make analysis work.
Thank you, Sarah. And I think there's nothing wishy-washy when you then apply that answer to the issue of things like vaccine hesitancy. Elizabeth, would you like again to come in and more or less sum up as well?
Yeah, I think we've sort of covered the things I would have thought to cover. So happy to just pass and then have more time for questions.
Right. And Rumi?
Yeah, I think it's been a really comprehensive panel. I think in the end, the bottom line is data doesn't tell the whole story. And just to maybe recap, as Sarah was saying already, and I think we all talked about a pluralism of like the kind of knowledge we need to look at such challenges, and statistics is an important part of that too. And I look forward to discussing more too. Thank you.
Yeah. Okay. And Owen,
Yeah, so just 2 quick points. One is around just being aware of paralysis by analysis. I think at times when you're looking at inequalities, that happens a lot. So I always encourage people to say, always remember what we're trying to achieve, the outcome we're looking for, which is to try and reduce inequalities in healthcare. So instead of spending way too much time reanalyzing and analyzing data and trying to refine the methodology, which is really important, but to always come back to the point about what you're trying to achieve. Then the last point I'll make is around always talking to the experts. I always tell people that I'm not a race expert. I'm an analyst and a digital health person who is working in the Race and Health Observatory. I'm not a race expert. When I'm trying to understand things around race, there are other people I'll reach out to. And that's what I always tell people, that the fact that someone is a professor in neurology and they happen to be Black doesn't make them an expert in inequalities for Black people. If I want to be treated for neurological, definitely go to them. But if I want to understand inequalities, the other people are put in front of them. Thank you.
I think I now have a question from the audience on which I think is a really good one, dealing with intersectionality. And I think we partly covered it, in particular ethnicity and deprivation, but I think intersectionality is something also that has been touched on in this discussion about the way in which particular characteristics combine in different groups. Elizabeth, do you want to talk about some of the techniques for dealing with intersectionality?
Yeah, it's a great question. And I think there's a few things I might think about. First, of course, we would need to have the measures of the different sort of aspects that we're thinking about. I think I went to the Slido quickly, like ethnicity and deprivation. Hopefully we at least have measures of both of those things. Certainly, and then I think we have to sort of make sure that we interpret the findings sort of in an appropriate way. I mean, we can look at things like interaction terms and we can have both variables in some model, but we have to also then be mindful of sample size, and that sometimes I think sometimes there's a tension of sort of, we need to figure out how can we answer these really important questions, but in cases where maybe the sample sizes are small, and sort of reflecting the uncertainty that we have about those. Certainly again, I mentioned earlier my work in generalizability of randomized trials, and often our sample sizes are very small. And so I think we also need to be thoughtful that if we want to answer nuanced and important questions about things like intersectionality, we have to do that from a design perspective and sort of think from the beginning, how do we make sure that we collect the data that helps us answer these questions? Because if we don't do that, it's possible that the data we end up with is just going to be insufficient to really be able to investigate all the questions. So others probably, actually the other thing I want to mention is the other nuance in a causal inference context that can be very challenging is figuring out sort of what variables are kind of appropriate to adjust for and what you shouldn't adjust for. And there's this term of like allowable covariates. And there I'm really just going to refer to some work of a colleague of mine, John Jackson, who has done some really thoughtful approaches to how we define different terms and then use methods to try to disentangle these different pieces. So look up John Jackson at Hopkins for some really nice work in that area.
That's helpful. Rumi, did you want to add anything?
Sure. Yeah, building on everything said, which is very important. I guess just, from my own learnings from the science around health disparities and how a lot of what we're talking about in terms of intersections are like reflecting sometimes we just think about things at the individual level. And so really, we have some, systematic forms of, different kinds of oppression, racism, classism, sexism that's interacting with like ascribed individual properties, which are also socially constructed. And so it becomes, you know, a little bit more complex, right, as Liz was saying, than just, you know, putting interaction terms on these things. But I'm at the same time positive, look, you know, as from my read of that kind of literature, some wonderful work from, I mean, stalwarts like David Williams, et cetera. They do, you know, we do need better measures of these kinds of discrimination and whatnot. And as statisticians, you know, we can work on those measures and to enable those analyses. So thinking both about the complexities of these concepts, create a measurable form that we can talk about, realize, you know, with the, you know, knowing that it's not the whole story, but at least so we can assess where we are and assess where we're going. So I guess I would just add that creating this kind of information or data we can use to talk about these problems is an important challenge that we can look at and make some room on too.
Thank you. Could I go to Sarah, but also ask her to, as well as touching on that, to elaborate on examples where you use data linkage in ways that prove to be problematic. Any issues, specific issues with data linkage?
So I'll start with the second point of the part of the question. I was just trying to look it up, and I'll put a link to some of the news stories in the chat. It wasn't, I was wrong to call it data linkage. It was more of a data sharing question. Yeah. So I think people will know there were legal challenges to the sharing of information between the Home Office and NHS Digital, I think it was at the time, as to and it was part of enforcing people's, essentially around people's migrant status. And then there was another example where local councils were sharing information on rough sleepers, again with the Home Office, and again that was subject to legal challenge at a later time, where that data was not being used lawfully. And so I suppose you could say, well, the law did work in those cases, and that was protected. But I do think it does show that that these things can be done and do need legal challenge and legal protection, to make sure they're being that the law is being followed, and that's why that's there. In terms of the question around, sorry, the earlier question around intersectionality. I have to say, I was like trying to take notes on Elizabeth Stewart, thinking, oh great, she's going to tell me how to do this, because we really struggle with this a lot, and particularly because we would have interest from, say, directors of public health at a regional level to say, well, we want to know ethnicity and sex and in my region, and you immediately get down to very small numbers. So I'm afraid I don't have an answer to it. I just know that there is an awful lot of appetite from people working on the ground to address this, and I have found that it's just really difficult, and that I haven't found a way to do it other than laying out some just really clear stratification so people can see the patterns, but you immediately get into very difficult issues around small numbers quite quickly, sometimes quicker than you think.
And potential disclosure. So if I can ask just to wrap up, and I'll just put this out to anyone who wants to, are there questions or applications within public health that you would like to see get more attention from the statistical or data science communities? Does anyone want to pick up that question with a quick answer? Yes, Elizabeth.
Yeah, I would just take the opportunity to sort of highlight that these are really fun. These questions that we have are like about representativeness and like the design of studies, how we link data sets in appropriate ways, are not necessarily, I think right now in the field of statistics and machine learning, are not sort of hot in a sense. I think people like to sort of propose some fancy new estimator and sort of some variance calculation. And I would just sort of put out there that these are also really important questions. And again, and it's sort of, it might not even be necessarily super fancy statistics in a sense, but it's thoughtful and careful approaches to design and analysis. And just a real focus on sort of where does data come from? How do we think about survey samples, or how do we think about all this? So just a plug for sort of getting back to some of these core
Yeah.
statistical ideas is really
getting
important.
back to basics.
Yeah.
Owen, last word to you, Owen.
Yeah, sure. So I'll just quickly touch on all the three things. So in terms of intersectionality, always ask yourself why you want the data to be looked at in a intersectional way. Don't just look at intersectionality for the sake of it. Comes back to the point I was making. If you talk to the experts, you need to find out why. If you look at maternity outcomes, mothers in the least deprived areas who are from a Black Caribbean background have got worse outcomes than white mothers in the most deprived background. So look at it just from an intersectionality point of view, because you had the word somewhere. But not just be good. Always talk to the experts and try to understand why you need to look at it that way. Then in terms of what I would like to see happening, I always say to people, if you're working in healthcare, regardless of what you do, I'm an occupational therapist by background, always check in your service, have the data split by different demographics and look at the outcomes that people are being referred. I once did work where in one organization where the authorities had never ever looked at any of their data from an ethnicity perspective at all. So that would be my challenge to say, if there's one thing you can do today, if you work in any setting, just go and say, look, all the key performance indicators we look at, can you please split them by the different demographics and see what that tells you.
Thank you very much, Owen, and thanks to all the members of the panel. I think it was a really constructive panel meeting, and I hope that the audience have gone away to look at some of the references and links that colleagues have provided. Thank you very much. Back over to Britt.
It's my great pleasure to introduce the chair for our final panel today. Professor David Leslie is the Director of Ethics and Responsible Innovation Research at the Alan Turing Institute and Professor of Ethics, Technology and Society at Queen Mary University of London. And he's also one of the co-organizers of this workshop. So I'm very pleased he's here today to chair this panel. And before I pass over to David, I just want to gently remind the speakers that we're working to quite a tight schedule. So I've given David permission to take an autocratic stance to chairing this panel. So yeah, please do make sure you use the raise hand button if you want to speak to like a general question, but otherwise I'm sure we'll manage. So over to you, David.
Thanks, Brio. That might be a bad suggestion on the autocratic side. I write on democratic equities, so I usually I'm all for participatory parity and these things. But okay, I'll try my best to keep time. So yes, I mean it's been a real pleasure so far to take in all of these really valuable contributions. I think that acknowledging the importance of context, thinking of context as key, prioritizing more holistic approaches to the ways in which statistical methods can be used to confront some of the health related questions that we're asking, clinical questions we're asking, the public health questions we're asking, and finally now pharmaceutical questions we're asking is so important, as well as domain knowledge. In fact, when we think about or talk about the cascading effects of health and healthcare inequities in data, in the design, development, and deployment of statistical methods, we are really enjoining a kind of socio-technical approach, which is to say, really paying attention to how things like unequal access and resource allocation, underrepresentation in things like clinical trials and say genetic studies, structural biases and research agendas, how these kind of factors, real world patterns of health inequity, contextual factors do manifest in the representativeness of data sets, the way data is coded, the way statistical methods are deployed. And so just to sort of maybe sense check and start with that lens to open this last panel. And it is important, even when we talk about pharmaceuticals, to think in those socio-technical terms, just to say, even though it may not be as apparent, for instance, as when we think about the clinical environment, which does manifest biased practices in different ways. So let me introduce, if I might, the esteemed members of our panel today before turning over to them for their own kind of initial insights. Dr. Aylin Kakiroglu, I hope I've not butchered that name. You can correct me when you come on. Aylin is a senior AI scientist at Benevolent AI, where she develops methods to extract information from scientific literature and clinical data in combination with genetic and molecular data for drug discovery. Dr. Felix Greaves is our second panelist. Felix is Director of Science, Evidence, and Analytics at the National Institute for Health and Care Excellence at NICE. He's also a clinical senior lecturer in the Department of Primary Care and Public Health at Imperial College London. Dr. Chris Harbron is an expert statistical scientist and advanced analytics lead at Roche with over 20 years of experience in the pharmaceutical industry. He's a key member of the strategic partnership between my own institution, the Alan Turing Institute, and Roche. And finally, last but not least, Professor Keith Abrams is Professor of Statistics and Data Science in the Department of Statistics at the University of Warwick, and is NIHR Senior Investigator Emeritus, as well as being Honorary Professor in the Center for Health Economics at the University of York. So with those introductions, let me welcome the panelists to just kind of maybe open up with a couple of thoughts on their own interests in health equity and how statistics or machine learning is used in their kind of participation in the pharmaceutical world to understand or even to reduce health inequalities. And so why don't I start with, thanks so much. Why don't I just turn to Felix now, if that's okay.
Good, is that coming through?
It is.
Perfect. Excellent. Well, first of all, thank you so much for the invitation. Thank you. It's a wonderful sort of initiative, this wider network set up, and a pleasure to speak with other such more learned colleagues than me today. But just reflecting on the point of view from NICE, so we are the national agency that does health technology assessment, and we also sort of produce guidelines for the health and care system, including public health, trying to reflect what great care looks like. So from the point of view of pharmaceuticals, so I may touch on some of the other aspects that we do. We are in the, well, if Benevolent do wonderful work in the early days of drug discovery, we're at the other end of the spectrum. We think about market access. We think about when sort of treatments have been developed, discovered, tried out, and sort of demonstrated their safety and efficacy, we hope, through an appropriate process of clinical trials. We're in the business of seeing whether they are cost effective, doing health economic analysis and making recommendations for the wider system about, particularly NICE, if it gives a recommendation that a treatment is cost effective, creates through one of our health technology appraisal approaches, we create a funding mandate, therefore a mandate to the system, to the NHS in England at least, that these are medicines that should be used. I suppose those questions of inequalities, I mean, these are hard questions to answer for society. We realize that we're in the business of trying to allocate most efficiently for the benefit of the whole population and for the individual patients in front of us, a limited set of resources. So we try and do that as fairly as possible. And issues of inequalities, I think of NICE is it's about just over than 20 years old, are baked into our way of thinking, we hope, but something we always seek to look more broadly at within our initial social value judgments, statements that we worked to in our early days. And now we have a set of documents called the NICE Principles. The health inequalities aspects sort of are called out explicitly as something that we should be looking at and something we do try and look at in every decision we make, whether a guideline or for a new medicine. But, and I suppose here's the rub, we do it largely on the basis of the data that are provided to us from the trials that come through the system, from the and to a point, we are aware that, while in the pharma space, at least, trials are, normally very well conducted, efficiently organized and provide high quality, well regulated sort of data on outcomes. they often don't come from the most diverse group of people. And I'm sure you've been talking about this over the course of today, so I won't delve into it, but we have to do with what we've got. And so being aware of the limitations of the evidence that presented to us, how diverse was that trial, I think it's something that's very high in our thinking. But actually, as we move into a world where, of course, we will still trust and rely on the RCT, which remains, at the top of an evidence pyramid to produce unbiased estimates. At the same time, we're increasingly using real-world data, not to chase the overpromise of things in this discipline, but realizing that actually the opportunity to look to see from the data that we have from the UK health system, increasingly available and well coded often in terms of who's had access to drugs, there's questions of, well, this was the claim in the trial, what does it look like in the real world? So we're keen to explore that. For cancer drugs through a process called managed access, when there isn't complete data or their data is still emerging, we release them funded through the Cancer Drugs Fund earlier into the market than before we have, as it were, perhaps definitive data. A new fund called the Innovative Medicines Fund, we do that with other drugs, and actually increasingly in medtech, beyond the remit of this pharma talk, but we look to see, sort of, for example, digital therapeutics. We're looking to see, we're making a recommendation earlier than historically would have done, and then we are looking to collect data from real world evidence to see actually how do they perform. And I think there are some real opportunities here as we get not always perfectly coded, but hopefully broadly representative data from the UK health system about how well these things are performing. So yes, we're at the business end of looking to see whether drugs work, whether they're cost effective. We are very mindful to the data that comes in, but we're limited to what comes in. We're increasingly using real world evidence systems to try and capture and try and measure in the real world how well these things are working. I won't witter on for longer, but looking forward to the discussion.
Thanks, Felix. That's really nicely framed, and it also brings up an issue that we should explore in a bit, which is when we think about inequality and inequity, some of this needs to be thought of at the ecosystem level, right? As you're saying, market access level, how the market is shaping, or how the funding is shaping the bringing products to the market. But then there's also the data and model kind of level, right? Where we're thinking about the data, we're thinking about the biases within the context of the science, of the actual model and science. And so it's we have to sort of move back and forth between those two levels. Chris, why don't you say a few words?
Right, yeah, no, thanks, David. Yeah, thanks for the invite to be here today. Yeah, so I'm working with Roche, one of the pharmaceutical companies that provides the data for people like Felix to make the assessments on. And Roche is interesting because it's both a pharmaceutical company and a diagnostics company. So it sort of produces very different types of products which are related to each other. And clearly we've got an interest in making sure that our our treatments, whatever they may be, are as widely made available and given as much access to people as possible, when many people can get as benefit from them as can do. And we've also got sort of the point that we're a multinational company. So basically we're selling our treatments globally. And so we've also got this global dimension. We're interested in maximising the access and the fairness, both on a global scale as well as within country scale. And we've also sort of feeling the downstream recognised that certainly some of the regulatory authorities have made it very clear that some of the issues Felix just alluded to, that the representativeness of the clinical trials not being that representative wasn't good enough. So the FDA, for example, have given out some very clear guidelines over the past few years, really stating that they're expecting the clinical trials to represent the population that they're recruiting that has that disease within the country. Which is interesting because it actually produces certain challenges in order to do that. There's also a great opportunity actually to increase the number of different sites, number of physicians we're using, which at the time it's actually quite difficult to recruit from clinical trials. There's something, it's an opportunity for us to get some advantages there. In terms of sort of our thinking the ways of addressing this, one area is certainly sort of about, again, sort of making sure that data is representative in the first place. Yeah, we're sort of introducing a lot more monitoring into our clinical trials to make sure it's, yeah, we do get the sort of the balance between the different types of population we want to do, or at least we're very aware of if we are moving away from that desired outcome. We're also in situations where we can start to, actively promote the generation of data in cases. A couple of examples of this would be, we've got part of something called the African Genome Project. So I think, one of the clearly recognised problems is the vast majority of human genomes that have been sequenced comes from Caucasians. What's actually the greatest majority of genomic variability within humans occurs within the African population. So what we're doing is trying to promote this African Genome Project, which A, will generate that data, but B, generating infrastructure allowing many more genomes to be sequenced from an African population in the future. The other sort of aspect is touching again on the real world data that Felix mentioned, that is, we're increasingly using both sort of reasons of market access and having conversations with organizations like NICE, but actually also for internal decision making. And we sort of set up various what we've called shining towers, but within basically for our local affiliates in various countries around the world where maybe there isn't quite that infrastructure available at the moment, which we do have, say, for example, in the UK, just promoting that aspect and helping to generate the data which is going to be of sufficient quality and a sufficient things such as the standards, allowing them to be utilised for doing valuable medical research. So I think that's all I'll just say for an introduction.
Thanks, Chris. And just to remind everybody, please, if any questions come to mind, there's a link to our Slido, and feel free to put those up in the Slido so we can answer them at the end. Keith, why don't you say a few words now?
Great. Thank you very much for the introduction and invitation. One of the benefits of going last, of course, is that I can pick up on all the points that people have already made. My sort of background is in a way spans what the other panelists have already said, in that I work with industry in terms of designing clinical trials, synthesizing them, and so on. But I'm also on, I spent many years on the Technology Appraisals Committee at NICE. I currently sit on the Diagnostics Advisory Committee. So I also see it from a decision maker's perspective. And as others have sort of said, but in terms of clinical trials, the issue is very often when we are making decisions, and whether that's internal company ones or reimbursement ones, is the representativeness of the trial to the target population, and obviously that is very often that is a concern. But one thing which I think Chris sort of alluded to it just a minute ago, is that we tend to think we perhaps often think about representativeness in terms of individuals, but also it's the trials themselves that, especially if you're a decision maker in a sort of an LMIC, and the trials have all been conducted in the US or Europe or Japan. How representative are they of the health system, and are the relative treatment effects that you're getting from the trials transferable to those other settings? So I think that's a really important question, and I know one that people are wrestling with. The other angle, other panelists have mentioned real world evidence, and I work a lot with real world evidence, both in a population health context, but also in an HTA one. And one of the things that I'm interested in, and I think it potentially is a real problem with using real world evidence where it's routinely collected, is that of course it's collected for reasons other than rather than research and decision making. It's collected as part of clinical practice, and so there are actually issues about over-representativeness of some people. So, you know, for instance, if you've got a electronic health record data set, some people in it will have lots of, let's say, blood pressure readings, and others will have fewer. And of course, the reason is, you know, there are underlying reasons, and so the data generating mechanism is different, and we really need to both understand that, but account for it when we're using these routine data sources. But the other opportunity that I think is particularly interesting is we tend to think of clinical trials in isolation, and I think there are some really good examples. Salford Lung study is one example where we can nest trials within a much larger data ecosystem, and therefore get the added benefit of real world evidence to perhaps try and, you know, generalize the results of the trial brought again, sort of perhaps in a broader population, and so on. And so this aspect of future in the future, designing studies in perhaps a more efficient way that can help address some of these issues. In the meantime, of course, you know, we've still got to make decisions, and so, you know, things like the reweighting of trials to try and assess whether or not the effects that we did see in the trials are representative of our target population. I think you know, I think there's no other alternative really, and of course that then brings in the discussion of, well, how exactly do we do that? So I'm really looking forward to lots of other aspects of the discussion I'm sure people are going to raise.
Great. Well, let's move to some questions, taking into account all of those really interesting observations. So maybe, Aileen, I'll ask you first about the kind of most salient sources of bias that you find in your work, or that you encounter in the type of research and innovation that you engage in, and also thinking in particular about issues such as, we've talked a lot about representativeness, but other dynamics, missingness, other dynamics of context. What kind of biases do you face in the science? Do you have anything to? Would you add anything to that in terms of other sources of bias that you confront, or that you feel like are present in Roche's pharmaceutical practice?
Yeah, I mean, I think so supposedly we sort of take there's two different types of data. So one is clinical trials data, and then in a lot of ways, clinical trials data has been designed not to have two biases in there. You know, it's got blinding, it's got randomization, it's got pre-specification, a whole range of features to try and remove biases in there. But there is still going to be these questions about the representativeness within there, which, yeah, is something we can address. I think the questions about missingness there were really interesting as well. Because that can come in many different ways. You know, there's almost some structural type of missingness comes in places. You know, if we're looking at some sort of advanced, I don't know, imaging method or technology, that may just not be available in some more developing countries. They just don't have the infrastructure of that. And other countries may have restrictions on what you're able to do in terms of genomics data. So then we end up sort of with holes in the data set because of that aspect of things. You know, I think I sort of mentioned before, if we then move on to the real world data, then that's, yeah, becomes much more apparent that there are, you know, biases occurring there. You know, and again, some of these kind of just reflect what's going on in society as a whole, yeah, more generally. And again, the nature of these biases can vary very greatly from country to country. You know, so within the UK, we've got the Single National Health Service. The data missing this type of mechanisms are going to be very different to, say, the US, where you've got an insurance-based systems, and probably going to see much more levels of inequality in healthcare there. So a whole range of that. So it's very important to be understanding what's behind this data and what's behind sort of the differences that we see there. Yeah, and I guess the other point just to sort of mention is that there is something about sort of people like the comfort of seeing data, you know, and I sort of think for the example there that maybe if we were looking to get the drug approved in France, the French regulator, and it's been a multinational trial, the French regulator may actually just focus in on those 10 patients who are from France there, which then probably from a statistical point of view isn't too helpful because that just becomes the incredibly small subgroup. So then there's a question of interpretation about that. What level does it make sense to start slicing and dicing things and making conclusions about differences, and what questions it doesn't? I don't really have a clear answer to that, but it's just sort of raised as an issue.
Great. Keith, I wonder if you can speak a little bit to what's, given the biases that Aileen and Chris have been talking about, what, if anything, is being done to detect, quantify, or correct for the kinds of biases that are being talked about? Can you just maybe give us a landscape view of some of the more effective tools that you see?
Well, I mean, I suppose I mean, in terms of missing data, then obviously the current methods that people are should be using, you know, such as multiple imputation and so on, can help to some extent address those that were missing this as perhaps conditional on covariates and so on, then that they can work to some extent. I suppose the other approach is to trying to think about generalizing trial results, or it doesn't have to be a trial, but you know, study results to broader patient populations are methods such as reweighting. Now, the success of those methods, of course, depends on the potential overlap between your target population and your clinical trial. But if you're wanting to apply your clinical trial results to a population which basically there are no patients who come from that population in your trial, then they're going to be less successful. And so in some ways the methods can be limited. You know, it just depends on the context. But you know, they you know, I've used them in practice, and they can work. Other approaches, which are more sort of, I suppose, going to the sort of geographical aspect. There are approaches which essentially are hierarchical modeling approaches, and I think sort of Chris and Aileen mentioned examples where you know, to what extent are studies done in some countries similar to studies done in you know, other countries. And you know, I mean you know, I'm sure Felix would agree, yeah, at NICE there is a sort of ranking that, you know, if we've got studies done in other European countries, then we might sort of deem them to be more similar to what would have happened in the UK. US, very different healthcare system, so perhaps less so. And so there are ways of doing that formally, of modelling and so on. The other thing I just wanted to mention though about, so they're some, and that's not, I mean, you know, there are other analytical approaches, but that's the flavour of the ones I'm familiar with. But the other thing that is what I think is important to think about is that there are initiatives we've been talking about missing data and data collection in clinical trials and clinical studies, and of course there's huge opportunities to improve data collection with technology and digital data capture and so on. And as technologies themselves are digital, we can do that. But that raises another issue as to, are we replacing one potential bias with another, that we need to think about digital divide, and that sort of are, saying to people, well, you just download the app on your smartphone, assumes that everyone's got a smartphone. So I think we need to be careful that we, in trying to address some issues, we don't actually introduce others.
I think Felix, actually, I wonder if you can just kind of respond to this question of how NICE would address the second layer that Keith has just kind of brought up, which is this inequality, digital divides layer. Is there a sense in which we're just trading up for different forms of inequality?
Yeah, well, I'm just reflecting on some of the stuff from my academic affiliation. Some of these digital divide things are very pertinent. I'm analysing I'm doing the NHR evaluation of the NHS app at the moment, which is massive population uptake, over half the population using it. But actually, and getting hold of sort of data at the individual level hasn't been possible yet, and will require some quite complicated information governance appropriately. But you can see just from the patterning at the local level that we're seeing much higher usage in. It's the classic stuff: less deprived groups, less diverse groups, and things like that. So the risk of those people who are using some of this new technology, submitting their data into various different sort of pots. I was talking to the people sort of running our Future Health, sort of just very wise team doing that, and the very diligent effort they're putting in to try and make sure that in all the work that sort of Genomics England are doing to make sure that we're getting a broad spread of people, a diverse and representative group of people. But my goodness, it requires sort of effort and focus and resource, cash to reach those people. But just also to pick up on a couple of things that have been bubbling up in the questions. These questions of the use of real world data. It's really interesting. This, is the real world data representative? And it depends. We're currently trying to build sort of real world data infrastructure in the UK, and we're sort of having discussions about, should it be national, should it be subnational, and actually point, all of it is useful. Obviously, the broader kind of, I'd love to have full census data for the whole country, but we haven't got that for many things yet. We can get some pretty good data sort of coming out of primary care. So I think we take care whenever we're using the real world data to think about what and how that data has come from, how representative it is, how well coded it is. There was a really important point about making sure we've got the diverse teams, and NICE is we're on record saying we're sometimes not as diverse an organisation as we would like to be in our workforce, and we're making conscious sort of efforts to change that. Very consciously thinking about that in terms of our committee structures, those committees that sit in deliberation over the data and the recommendations, and so consciously making sure those are as diverse as possible. But then also methodologically, we're really interested in the difference between the trial data that we get from the colleagues in pharma and medtech that we work with, and just to build on the point from the colleague from Chris, from your point, we see the diligent work that pharma is doing in this space. Everyone wants to do this. Everyone wants this data to be better, and we absolutely sort of see the hard work that's going on. What do we do? So we try and think about kind of methodologically where we are at NICE. We've just for example, we're working with Laurie Tomlinson and the excellent pharmacoepi group at LSHTM, working with various TREs. In fact, the NIHR very kindly recently funded them to do. We will do sort of target trial emulation. We'll look at the real world data, because we've also got the RCT data, and compare and contrast. And so we're hoping to do a program of that over the, both our guideline work and our cancer work over the next few years, to see are we seeing similar numbers from different sources of data that we're and different methodologies that we're getting. So we're always on the lookout to improve our approaches, and always keen to hear the state of the art.
Great. I have a question. Maybe it's Alan would be the best to answer first, because you talked about how you're kind of building knowledge graphs to sort of pick up biological mechanisms and go for drug discovery. Now, the models are getting bigger and more opaque in a sense, as we kind of move towards more NLP oriented data analysis. I'm just wondering what type of implications that these techniques are having on surfacing potential biases. Are they blockers to surfacing biases? And how are you dealing with those types of issues? Do you have any thoughts on this slippery relationship between perhaps lack of interpretability in models or explainability deficits and how that sort of might present barriers to understanding models or the biases within the models? I'm wondering if you could say a few words about that.
Yeah, I mean, I guess the sort of example which came to my mind is that we may be in a position of generating a predictive model based on whatever data we've got, as an outcome, someone's outcome, for, I don't know, for lung cancer, say. And if often what people do is they just generally grab all the data that they have from whatever source it is relating to that and throw it into their favorite machine learning AI technique, whatever that may be. And often one of the variables that gets chucked in there is race, because that's collected in some sense. And very often race comes out as being quite an important predictor within the final model. But is it a useful predictor? Because within that is a very ill-defined term. It's probably a proxy for something else within there. Now, whether that be some genetic background, whether it may be some socioeconomic thing going on or whatever like that, it's probably not going to be, it's certainly not going to be the sort of direct causal link behind this kind of things. And it's also a question, how do you actually use it in practice? Because typically that's going to be something which is self-reported. And so, people's interpretation actually a lot of times what race they may tick within that box is not going to be a well-defined categorization within that. And it would seem very strange to then start potentially giving people's treatment outputs based upon such a strange situation. So it's sort of, we do have this situation that for whatever reasons, these variables can apparently be important, but probably not really given the relevant factors in there. So it sort of speaks a lot to me about the actual design. There's a lot of thought that actually it's almost collect the data and AI will sort out all the rest for us. But I think there's a huge amount has to go into the design of what we put into the AI, what we want this system to look like, how we want it to function, what features we want it to put out, that we need to build into this up front, rather than just relying on sort of the computer to come to an answer with everything. And I think there's also sort of a lot of things we have to be very cautious about, that actually we may be picking up other things because we know all these factors are so correlated with each other, which may be picking up this binary way, that even if we were to remove a lot of these variables, because of the complicated way which AI can work, finding multiple level of interactions, could we end up just finding some of these other features by chance? Not by chance, but inadvertently without realizing it. So I think there's a lot of due diligence we ought to be building into these systems, to make sure we're not picking up any identified features like that as we would take them forward.
Keith, I'm wondering if you have any follow-on comments to that and the interpretability question.
I mean, I think it's a really important question in terms of people's trust in the trust in both the data and the methods in a way. And this is one of the things I was going to raise, actually. So as I said, I sit on the NICE's Diagnostics Advisory Committee, and we're seeing AI technologies coming, and Chris and Ailey, well, all three of the other panelists will know the sorts of things I'm talking about, that sort of algorithms that might be used to help read CT scans and so on, whole host of them. And it was the point Chris just made about sort of the data and the algorithm, and when it's a static algorithm, you can look at the data, you can look at well, even if you can't look at the algorithm, you can look at the outputs and you can look at the evaluation of the algorithm and so on. But what is really difficult to think about is where the algorithm changes over time, and where the algorithm learns, so it's dynamic, and so we've had a couple of cases recently at night on the diagnostics committee that where it's almost been presented as a sort of on trust that this algorithm will learn and it will get give a satisfactory performance and so on. And I find those sorts of situations much more difficult to think about how we're going to evaluate them and so on, as opposed to things that we're perhaps more used to, some sort of risk tool. You can look at the data set it's been developed on and see whether or not it's acceptable and so on. So I think that going forward, I think that's a really big area that we need to think quite seriously about. How do we evaluate these dynamic systems?
Yeah, that one really is a complex headache, and one I think we're thinking about how to tackle methodologically. But again, we will and it's interesting to see there's a huge number of new frameworks coming out. You just need to see that, I don't know, the Starred AI, the Consort AI, everyone's sort of taking the existing sort of statistical tools or statistical reporting approaches and think about, okay, what's the AI overlay on this? And I think that's great and really exciting to see, though sometimes one wonders if, particularly on the dynamic bits, there really is some substantial extra complexity there. But just to pick up on that point as well, I mean, it's really exciting to see some of the new technologies come through, some of the AI-driven diagnostics, but just like in the selection of the population for the clinical trial, the selection of the testing and learning data sets for training these algorithms is, if we're honest, a bit of a menace, because often there's only, it's changing over time, but we've seen that there's been one or two major training data sets around the world for a particular problem. I don't know who's got the best data set around lung imaging, around breast imaging, or something like that. And they are becoming more diverse, but many of them, by virtue of the health systems they represent, or where they came from, where there was sufficient, where there was, a prior sort of expertise to create a data set that form, they're often deeply undiverse. And that question of, I don't know, an algorithm that was trained in just with the population of one country, maybe a small, quite heterogeneous country. Homogeneous country, I should say. How do we look at that sort of at NICE and try to apply it to a slightly more diverse sort of country? That's, I think there's quite a lot there, and standards and expectations around training data sets, I think, is something that will be, well, I know a lot of people are thinking about, but it'd be nice to see those really deployed in action at large scale.
Well, I think that what we should perhaps do to wrap this up is think for a second about both limitations in the current sort of statistical methods to mitigate bias, but also paths forward. So maybe just to conclude, I'll go around one more time and ask for any observations, thoughts about paths forward in this journey as it relates to the pharmaceutical industry.
Yeah, I think probably very similar comments to Aileen, actually. So firstly, I think we need to get the data, at least have a target of, getting the data as being as representative as possible. And that's probably going to need some really proactive work, in various different areas in order to achieve that. Generating data isn't easy at the best of times, and to do it in this way is there. So it's important, but I think we also have to be realistic and accept that is going to take some time to get situations where we're completely confident with that. In the meantime, again, I agree, I think it's something which you've got to give some really serious thought to on the methodological front, and the best way to approach it, given that we recognize that there's a certain group methodology about just really understanding that, what the size of the problem is, what the potential biases and implications could be of anything we've got going on at the moment. But then just start to think about the best ways of using the data. And a simple case here is thinking, if we think about machine learning as having a training set and a validation or test set, actually, what do we need to be thinking about? Is it, if we get something and we work it on the training set, for example, if that's not quite representative, but we show it's representative on the validation set, is that acceptable? Is that a more efficient way of using the limited amount of data we've got in a particular situation? So I think some sort of, research, some thinking about those sorts of questions and approaches would be useful.
Great. Felix, any last comments from the NICE perspective?
Not much to add beyond that, but the clear nod towards making sure we've got the diverse teams, the quantification of the problem, absolutely, and just we're really keen to see the progress in sort of the methodological work to see what NICE like standard and a standardized approach. Kind of, are we able to sort of agree around consensus around sort of standards and best practice in this area? That would be really nice and effective if we were able to do that. And it's nice to see some of the funders getting into that space.
Keith, the last word.
2 words, I suppose. Design. I think we need to think about the design of studies, but also I think the biggest strides in a way could be made by just uptake of some of the methods that are currently available that aren't terribly sophisticated, but actually get us a long way. And I'm, I don't see them being widely used. So I think better uptake of doing something rather than nothing would be my suggestion.
Okay, well, let me just take the opportunity to thank this wonderful panel, and then turn it over to Brio, who will close it up for us. I'm on time, Brio, by the way.
Yeah, perfect. Your autocratic stance really came to the fore there. Thank you, David. Let me just share my screen to wrap up. Thank you to all the speakers today and to the chairs for leading such wonderful discussions. I'm going to pop just a few links in the chat. The first one is a feedback form for today's workshop. We'd really love to get your feedback. It's a very short survey. It should only take just a few minutes, but it'll be really helpful for us on the organizing side of things. If you'd like to stay up to date with what's going on within data science for health equity, then you can subscribe to the newsletter. And if you're particularly interested in the statistical method STEAM activities and to stay up to date with the literature review that we'll be carrying out, then you can join the mailing list. And if you just pop your email into this, I think, Google form here, then that's the best way to do that. And finally, we're going to be running the second of this series of these workshops, which is focusing in on challenges to statistical approaches for fairness in genomics. And we've again got a really amazing lineup of speakers for that workshop. So that's next Monday, again, at exactly the same time. I'm going to pop the link to the registration in the chat here. And that is it. I actually just finished a couple of minutes early, so you can have your tea a few minutes early as well. So thank you again to everyone for coming along. It's been really great hearing all the discussions from the panelists and also getting your questions in the Q&A. So really grateful for everyone who's come along today. And yeah, hopefully see you soon at the next workshop or a future Data Science for Health Equity event. Take care, everyone.